Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
Tracy, you may have heard the story of the professional musician who played the violin while he was undergoing brain surgery at the Mayo Clinic. In fact, I think you saw briefly the cut that may be in the Ken Burns documentary coming up in September.
That's right.
Well, it's absolutely a true story. Playing the violin while undergoing brain surgery. Dr. Kendall Lee and his surgical team implanted electrodes into Roger Frisch's brain to stop a tremor that could have ended his professional orchestra career of more than 40 years.
It's amazing.
Yeah.
Deep brain stimulation surgery involves implanting electrodes within certain areas of the brain. These electrodes produce electrical impulses that impede abnormal impulses. Weren't working right before the surgery. Now it does.
Amazing.
Here to discuss is neurosurgeon and director of the Mayo Clinic's Neural Engineering Laboratory, Dr. Kendall Lee. Welcome back to the program, Dr. Lee.
Well, thank you so much for having me here. It's a pleasure.
Dr. Lee, good to see you again. So tell us the violin story. We're all dying to hear it.
Yeah, sure. So deep brain stimulation is a technology that now allows us to treat patients for a variety of disorders, including Parkinson's disease, tremor, dystonia.
Dystonia?
Yes, dystonia is a disorder where patients have very severe rigidity in their muscles and they cannot control it. And some of these patients may not be able to walk because of dystonia, or they might have their neck dystonia where they can't control the movement of the neck.
Okay.
And so as it turns out, this deep brain stimulation is now approved by the FDA for these disorders. Now, in the case of Roger Frisch, what he has is a little bit different from this movement disorder. You know, he is one of the concert masters with the Minnesota Orchestra who is a master at playing the violin. Now, I suspect because he practiced so much, probably hours and hours every day, that he developed what is called more use-dependent tremor. So somehow his brain circuits, and likely because of how much he plays the violin, developed an abnormal circuitry in his brain. Oscillation is what we call it, which is basically manifested as tremor in his hand.
Kind of an overuse syndrome.
Kind of, yes, exactly.
Okay.
You know, you probably heard of, like in golfers, certain golfers, because they're so good, they have what's called yips.
Yeah.
Mm-hmm.
Where right when they're ready to putt a very easy hole, their muscles tense up and they have a movement problem and they miss.
It's similar to that.
Yes, it's kind of
the violin yips.
Kind of, yes. Except he has tremor with this. And so when he developed this, he didn't know that there was anything that he could do. He went to a variety of physicians, but there was really nothing that was offered. Now, when he came to see me, he had his violin with him. He walked in, I saw him, and unlike my other patients, Parkinson's disease, essential tremor, dystonia, where I can pretty much tell what they have right away, I thought he looked perfectly normal. And then he said, well, wait. And so he then proceeded to take out his violin, which, by the way, is a very, very expensive violin that he brought to my office. And he started to play this music. And I'm not a musician. I don't fully understand. But when he played certain notes, you could hear vibrato, a lot of shaking. I didn't know he didn't mean to do that. But he said, no, he's trying to hold the note perfectly still, but he can't do it because he's having this tremor, only when he plays certain kind of notes. And so we presented him to our neuromodulation committee because this is an unusual kind of situation. And he was approved by our neuromodulation committee to undergo this surgery, which at that point, we were not 100% sure that we could help him. And so in the operating room, typically for the deep brain stimulation surgery, I do the surgery with the patient awake, particularly in situations like this, because I don't know beforehand whether or not we're going to be able to treat this, and we need to know whether or not the tremor goes away with the stimulation.
So they need to be awake during surgery.
Yes. And in this case, it was unique because not only did he have to be awake, but we had to have the violin.
You had to play violin.
Yes, we had to have the violin because that's the only time that the tremor comes out.
And if you have not heard about this, and you can see more about it in Ken Burns' documentary that's coming out this fall.
Yes, we're very excited about that because Ken Burns, this world-class director, who also did Ken Burns' Vietnam War.
Civil War.
And Civil War, yes. And he came and for the past, I believe about 3 years, he's been filming different patients and different aspects of the Mayo Clinic. And this was one of the stories that he found interesting and followed up on.
So how does deep brain stimulation work?
But I got to ask you, though. You say the patient is awake, but you got to put a hole in the skull to get this needle in.
Yes.
Now, they're not awake for that when you drill the hole
No,
in the skull.
they are awake for that.
You do it under local?
Yes. So, just like a dentist would use Novocaine to numb up the teeth, it's the same type of anesthetic that I use that numbs up the skin and drill a tiny little hole in the skull. But by the way, this surgery is incredibly precise. It's done using what's called a stereotactic head frame, and we get an MRI. So even though we don't see inside, like through an incision, we actually can see the brain through the MRI, and we have the ability to target very, very precisely within any area of the brain.
So how did you know where you wanted to put this needle?
Yes. So
there's a little place there that says can't play violin, and you stick the needle in there?
Yes. Actually, this is one area of research that we've been doing research on in the Mayo Neuroengineering Laboratories, exactly what you just asked. So how does deep brain stimulation work? And we have developed several technologies to figure out how it works. And in particular, we're very excited about technology called the WINK system that we have now tested that shows that it appears that deep brain stimulation can release different kind of neurochemicals in the brain that stops abnormal oscillations, or these are oscillations that ultimately cause the tremor. And DBS appears to release those chemicals that causes that kind of tremor. And furthermore, we now know we have a marvelous map of the brain circuitry. We pretty much know all of the various circuits that's causing this type of tremor. And in this case, it's coming from an area of the brain called the thalamus, which is center of the brain, deep. That's why it's called the deep brain stimulation. And more specifically, called the VIM, ventralis intermedius part of the thalamus. Now, this case is unique because that's the usual area for essential tremor. When we did the surgery on that area, he got, pretty good tremor control, but it wasn't perfect. And the interesting aspect that also Ken Burns picked up on is that we had to then add a second lead that is not so usual. So we needed to find that.
And he okays it in the movie.
Yes, that's right.
Yeah, we saw that. That was great.
Well, I mean, let me be clear. This is still brain surgery, and therefore it has inherent risk. And I, of course, had to discuss all of this with Mr. Frisch and all of my patients, that it has risks such as causing a bleed, hemorrhage, stroke, and so forth. So we have to take those risks. But in this case, the potential benefit far outweighed, in our opinion, the risks that he took.
For his quality of life, it was a deal breaker.
Yes, absolutely. The amount of tremor that Mr. Frisch has actually would be considered, not so much in the sense that you and I, if we had it, it would not affect our life. But for him, because he's a concert master, this was actually devastating.
Yeah, now the other interesting thing is he has a remote now where he can turn these electrodes on or off if he's not using them, if he's not playing the violin, right?
That is correct. So he can, and as soon as he turns it off, all of his tremor comes back.
Which he demonstrates in the movie.
Yeah. Now the other interesting thing is when we added the second lead in another area, just in front of the VIM, what we discovered is his tremor control actually is almost supraphysiologic, meaning that, everybody, you and I, under certain conditions, would have a little bit of tremor, physiologic tremor. Well, interestingly, he can now hold a note almost superhuman, meaning that he can play that violin even better than before.
Well, that's not fair.
That's wonderful.
All right, we've been talking about deep brain stimulation with Dr. Kendall Lee. Time for a short break.
When we come back, we're going to get a very exciting update on a story we've talked about before, electrical stimulation device that's being used on a spinal cord injury patient, allowing them to make step-like movements on their own.
Can't wait. You're listening to Mayo Clinic Radio on the Mayo Clinic News Network. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
We are with Dr. Kendall Lee. He is a neurosurgeon at the Mayo Clinic, and we've been hearing about his deep brain stimulation techniques, including the patient that had the problem playing the violin but can do it now even better than anybody else. Great story, Dr. Lee. Now I want to ask you, would like an update on the stimulation of the spinal cord in patients who have been paralyzed and potentially can get some return of function.
Yes, this is another technology that we've been working on here at the Mayo Clinic for about 4 years now. We've been growing this program slowly, and I'm very happy to report that this is another technology that is emerging to be very powerful. In addition, it is also allowing us some interesting understanding of how volitional control of movement happens. What that means is, how does the brain control our limbs voluntarily?
So this is the finding that was just reported in Nature Medicine.
Yes, that's correct. So maybe I can tell you a little bit of background on this. So about 4 years ago, Dr. Reggie Egerton and Dr. Susie Hakima had published a paper, very interesting paper, where they implanted patients, at that time about 4 patients, where epidural stimulation below the level of the spinal cord injury could cause voluntary movement back in the lower extremities.
So, epidural means
above the dura. So this
and the dura is the outer coating around the spinal cord.
That's correct. Yes. Okay. So this is technology that is essentially same as what we use for our pain patients. So as neurosurgeon, we implant
TENS units, you mean?
No, these are not TENS units.
Under the skin, but outside of the spinal cord?
Outside of the spinal cord, but just outside of the covering of the spinal cord.
Okay.
So these are actually surgical implants, and what's been demonstrated with these devices in pain patients is that they can help with pain. So this is already approved by the FDA for pain. Now, what Dr. Hakima and Reggie Egerton's group did was to now apply this technology in spinal cord injured patients who've been paralyzed, for example, with a thoracic or chest level, complete motor and sensory, meaning they can't move their legs or sense, there's no sensation. So when that paper came out that you can get movements, we were very excited about it because this really changes our whole view of what we can do for our spinal cord injured patients. Mm-hmm. So we teamed up with Dr. Reggie Egerton's group and decided, can we replicate those studies? And so initially, the goal of this study, which is Mayo IRB approved, Investigational Review Board approved, as well as the US FDA, to do this study. And so we've implanted now 2 patients under this study. And this paper that is being reported in Nature Medicine demonstrates that indeed what was found was true, but we actually went beyond that replication. So the replication portion of it, we actually already published in Mayo Clinic Proceedings last year. Mm-hmm. And this was really exciting because our results confirmed the findings of Dr. Susie Hakima and Reggie Egerton. So that was exciting. But what we discovered is that we could actually go beyond that finding. And in this paper, what we demonstrate is that the patient now is able to stand and take independent steps. Now, he still requires a walker because he has no sensation still, but he is strong enough now to control his legs and make movements, stepping movements.
Now, that is an incredible story. Now, when the word gets out, isn't every paraplegic in the country going to want this?
Well, this is still very early stage research. Like I said, this is only one patient that we have reported in Nature Medicine. Okay. And so what I would say is this one study really challenges what we used to think what is possible for treatment of patients with spinal cord injury. But, as a neurosurgeon, I often see these patients in the emergency room after the trauma, and you can imagine how devastating such an injury is. But I think what our study shows is that there is this tremendous hope in being able to regain some of that function.
So you're regaining function, but you're not able to cure or fix the fact that they are paraplegic.
Yes. Now, what is really interesting about this study is that the patient is actually able to control his legs again.
Wow.
And that's why this is such a powerful study, and I believe why the reviewers and Nature Medicine, which is one of the top journals in medicine, accepted this publication.
So let me ask you, if someone comes into the emergency room and they have cut a nerve in their arm or their leg, we can sew it back together and they get at least some return of function. Why is it that the spinal cord seems to have no ability whatever to repair itself?
You know, that's an excellent question. And we believe the reason is because while the nerve, those are peripheral nerves, and we know that those peripheral nerves can regrow. But the spinal cord is our central nervous system, and unfortunately, with central nervous system, when that system is cut, those nerves do not regrow. What we believe in this case, though, is that the question then is, how does the information from the brain that wants to move the leg regain that function? Mm-hmm. We do not believe that the nerves has regrown. We do not think that's how this works, but rather that during the trauma, there's probably enough connections that are not functioning enough, but that epidural stimulation allows these cells that's dormant to be able to once again regain its ability to get the command from the brain.
Incredible. Now, do you hope and suspect that someday people who are paraplegic or even quadriplegic, let's stick with paraplegia right now, the lower extremities paralyzed, will someday be able to walk?
Well, that's
like
the exciting
Superman
thing.
hoped?
Well,
yeah.
That's precisely what this patient did that we have reported in Nature Medicine.
Incredible story.
Where is research headed?
You know, I think now this is opening up a whole new direction in research for spinal cord injury. You know, before there's been tremendous amount of research effort and funding that went into trying to regrow those axons. Now, what I think will happen is that the research will be in these type of new devices. How do we now take this finding, which used a device that wasn't even intended for this purpose, now all of the things that we have discovered in this study, how then can we take that, take a step back and re-engineer the device specifically for this purpose of limb reanimation in spinal cord injured patients?
Does there have to be a different type of approval by the FDA for this?
Absolutely.
Okay.
And that's why I think we are in the very early infant stages of this technology.
All right, Dr. Kendall Lee, he is a neurosurgeon and director of Mayo Clinic's Neural Engineering Laboratory. Thanks so much for being with us.
Thank you so much.
Exciting stuff.
Thank
Thanks
you.
a lot.
I want to ask one more question based on time.